Hi, my name is Jerry Hesch. I'm a physical therapist and developer of the Hesch method of treatment. And this is part 4 of the case study, and we have, of course, 3 parts already posted on YouTube describing pudendal neuropathy. And in this, I will first do the blurb of my very small clinical practice, and I will then show you a website in which I post some ideas. And we hope that in time that website will become a lot nicer, a lot more representative of what we do. And this is that website. And we also have an educational component. We do teach seminars. Currently we are focusing on the Hesch method of treating the sacroiliac joint, which also integrates the pelvis as a whole structure, separate from biomechanics of the sacroiliac joint. We do teach sacroiliac joint mechanics for those rare individuals that actually have true joint dysfunction, such as peripartum, postpartum states, severe traumas, etc. Most of the time you're dealing with altered biomechanics of the pelvis itself, the hip, and the lumbar spine, but integrating those structures is sometimes challenging, and we make that pretty direct and straightforward. But getting back on the case study of pudendal neuropathy, the first 3 films that you'll see is one in which I took this client, Karen, as she presented, and she had already been involved in some care, some women's health care therapy, and that continued even throughout the care that I provided her. My approach to the pelvis is very different. The women's health PT approaches it kind of traditionally, kind of on the osteopathic model, which many physical therapists have adopted. It's also promoted under the term muscle energy model of sacroiliac joint mechanics. And that's more of a gross motion model, whereas the Hesch method is much more focused on, if it's a joint, does it behave like a joint? Let's evaluate it like a joint, much like we would evaluate the knee. So what I found on her second visit, after we had corrected the patterns that we saw on the first visit, when she came back for the second visit, those patterns remained corrected. The mobility remained improved, and we were able to peel away layers of that onion and get deeper and find out what the core pattern was. And it truly was the core biomechanical issue with her pelvis, because she did in fact have a dramatic reduction in her symptoms, and she's here today, and we can interview her and have her explain that to you. Again, we didn't fully resolve the pudendal neuropathy. Oftentimes treating something as severe as pudendal neuropathy is in fact a team approach. And I'm happy to be the person that balances the pelvis so that there's less external, if you will, and perhaps even internal mechanical stresses on that nerve. And that nerve does come out of the greater sciatic notch, wraps around the sacrospinous, and ligament goes underneath the sacrotuberous and re-enters the pelvis. So it is in fact vulnerable to muscle pull, fascial pull, ligamentous pull, and if the pelvis is asymmetrical, then forces acting on that structure are in fact affected. And in this case, she really did have a true sacroiliac dysfunction, sacroiliac joint dysfunction, and a true symphyseal joint dysfunction, in which the symphysis pubis was in fact rotated, and that would cause more tension and compression on those ligaments and on that pudendal nerve. Specifically, the traditional approach to screening the symphysis pubis involves palpating the top, which is the crest. Now one has to be cautious, because you do have the tendons coming down from the rectus abdominis, and if one side has more tone, you might indent against that tendon, feeling the tendon and believing that you're on bone. So you have to make sure the client is in a position in which their abdominal muscles are relaxed. 3 pillows under the knees, very helpful in supine. And you want to push past the tendon and come down on top. Well, she happened to be symmetrical across the top, which is called the crest. The other palpation that's done in the traditional approach is the front, which is called the tubercles. And that is palpated to discern anterior and posterior relationships, whereas the crest is done for up and down. Now the Hesch method actually palpates across the entire symphysis pubis, from one pubic bone onto the fibrocartilage and across to the other side. And I think you'll recall from the first visit that she did in fact appear to have a depressed fibrocartilage, which we corrected. And the Hesch method also acknowledges that the symphysis pubis and the pubic bones are long structures. Therefore, instead of only palpating the pubic tubercles, we actually palpate the mid-body and of course cross over and look for a indentation, or most people you can slide rather straight across. And then we also go down to the lower part of the symphysis pubis. And it's important to drape your client. If you lay a towel across them, they feel like you're a little bit less invasive because you are near the private parts of their anatomy. And so it does require a little bit of education, and it does require permission granting. But again, you are only palpating bone. You are not palpating their private parts. Okay, but you do want to palpate the lowest part because, as in Karen's presentation, the lowest part of the pubic bone on the right was anterior. And that means that there was a transverse axis through the upper symphysis pubis in which the plane, the face of the pubic bone was rotated. Okay, so there was an upper transverse axis, and rotation could not be discerned in the upper pubic area, but only in the lower. And spring testing revealed that it did in fact not move down there, where she did have mobility up here. And then when we evaluated her in prone, the right ischium was in fact more anterior, and the ligaments were tighter on the same side, and that correlated with the side of the pudendal neuralgia, which was symptomatic. So the treatment involved a passive force using creep, which is deformation over time, and we used 5 minutes to make the correction, and we used a fulcrum, and we got symmetry.